Good afternoon. Good afternoon, everybody. Hello, my name is Don Antonucci. I'm the president for Regence Blue Shield here in Washington, and I have to say we are a proud supporter of the State of Reform Conference. I was chatting with DJ a little bit in the hall coming out, as many of you have experienced some of these sessions this morning, and it's really, really some good dialogue happening, and I love the different points of view on the topics that I've heard thus far in the sessions this morning. And as DJ also mentioned in his opening remarks, you're all doing this now, but take advantage of the great networking and connections here, and also of the speakers that are hanging around afterwards and ask those follow-up questions, because bringing folks together like this, it's about us being educated, but as DJ had talked about as well, it's about us taking some of those ideas forward and having that dialogue. So today, I have the distinct pleasure of being able to introduce our keynote speaker. His name is Dr. Bruce Goldberg, and he and I had the opportunity to work fairly closely together in my previous role when I was the president of Regence of Oregon. And Bruce began his career in family medicine. He's a physician who's devoted his entire professional career to improving an organization, delivery, and the financing of public health care. During his time with the Oregon Health Authority, Bruce led efforts to improve children's access to health care and reduce hunger. He worked to develop plans for revamping the state's mental health system and promote education and prevention, and come up with the most meaningful ways and the effective means of protecting and improving the health of the state's residents. As an industry professionals, we know it's both a challenging time, and there's also a great amount of opportunity in this challenging time for an organization. And Bruce has gone through and taken advantage of opportunities, but he's also been somebody that, through some real challenging times in Oregon as well, was phenomenal and the consummate professional to work with. So without further ado, please join me in welcoming Dr. Bruce Goldberg. Thank you.
Thanks, Don.
Thank you.
Oh, it's great to reconnect with Don after a year when he left us in Oregon. And speaking of Oregon, I've got good news and bad news. One, the bad news is you've been invaded by Oregonians. I've met more Oregonians in the last couple of hours than I usually do in Portland. And the good news, however, is that they're going to keep me honest. I've actually had to revamp all of my remarks to be certain now that they really reflect what's happening in Oregon. And that's what I was asked to come here to do, is to reflect a bit on some of the things that we've been through in Oregon. But Monday is Martin Luther King's birthday, and he had a big impact on myself, and I think for a lot of us in the room. And I thought it would be appropriate for a moment to reflect on Dr. King and on his legacy, what it means to us, and what it means particularly for healthcare. I always carry around a quote throughout my career of Dr. King's that said, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And indeed, it is shocking and inhumane that for generations in our country, we've had such a great divide in health and in healthcare. You know, on one side of that divide are those who have the security of adequate health and adequate healthcare coverage. Those are the people who are able to see doctors and nurses when they get sick. They know that if the worst happens, a bad accident, an injury, an illness, their families will have help and they'll not face financial disaster. On the other side of that great divide are people without health care. Their lives are a lot less secure. They often forgo needed treatment, and if they get seriously ill, it can mean financial ruin or worse. And you know something? We all know those people. They're in our communities, they're our family members, their pictures are on the change jars in our local convenience stores. They're the source of pleas at our local synagogues, at our mosques, at our churches. This is a divide. But today, in 2015, as I stand here today, the first week of the year, we're a year into national health reform. And as I stand here today, I can see that for the first time in our country, things are changing. You know, national health reform, with all that it's been hyped up about, the thousands of pages of bills and this and that and all that, it's actually really pretty simple. It's a bridge. It's a bridge. It takes people from one side of the world, from insecurity to security. It takes them from being uninsured to having health care coverage. And it's a pretty simple bridge. Architecturally, it's really easy. If you're low income and you're fortunate enough to live in an expansion state, like here in Washington, you're covered through Medicaid. If you're a working individual but have never been able to afford health insurance, for the first time, you get some tax credit help to help you get health insurance. And lastly, if you've been denied coverage in the past because you've had a pre-existing condition, you no longer can be denied coverage and you can purchase the same health care as everybody else. It's really easy. It's so easy that millions in the US now have coverage for the first time, many of them ever. And here in our little corner of the Pacific Northwest between Oregon and Washington, our two states, we maybe make up 3% of the US population or something like that. Well over 1 million people now have access coverage, and they're crossing that bridge. They're going from being uncovered to being covered. Now, our states have a lot of experience in bridges. Some of those have gone well. Some of those, like the Columbia River crossing, haven't gone so well. We've also got some experience with our electronic bridges. Your bridge here, your electronic bridge to get people into coverage has done a lot better than our bridge in Oregon. We had some technical difficulties with our bridge. I think, as you know, it's had a couple of results. Number one, it caused us to manually have to row people across the river into coverage, but we've been able to get a lot of people covered. We've covered close to 500,000 people have been able to walk across that divide. And the other result has been what's likely to be a large and embattled lawsuit with our contractor. But, you know, just going from one side of that bridge to the other isn't enough. There are a lot of chasms and canyons that happen on the other side of that bridge. Another divide is that even for people who have health care coverage, inequities persist. And, you know, this inequity is heartbreaking in a system where our promise of a long and healthy life is most determined by where we live, our socioeconomic status, and the color of our skin. African American women in our country are 40% more likely to die of breast cancer than their white counterparts. Mexican Americans are less likely to have controlled blood pressure if they have high blood pressure than the rest of us. African Americans have the highest rate of premature death from stroke and coronary artery disease of any group in our country. And it's here in the Northwest as well. The death rate due to diabetes for African Americans in Oregon, where I come from, is more than twice that of their white counterparts. That's criminal. It's a little better here in Washington, 83% higher. That's a tragedy. The death rate for influenza and pneumonia among Native Americans in Washington state is almost twice that of whites. And throughout the US, communities of color pay a heavier toll of unemployment, poverty, and represent a disproportionate share of our Medicaid populations. We've got to address this. But, you know, sadly, there are more problems we need to address. Just because people have coverage in today's system doesn't mean they automatically get to see a doctor, get good health, and it doesn't mean they get the care that they need. You all know as well as I, we have a fragmented, costly, and inefficient system that often doesn't focus on keeping us healthy. There's a lot of waste. Don Berwick has quantified that waste and that inefficiency. You can read through it up there on the slide. But for those of us who work in our healthcare system, and for those of us who get care in it, and dare say that's now just about everybody in this room, we experience that waste and inefficiency every day. Not a user-friendly system. Yesterday, I spent 2 hours on the telephone trying to arrange and coordinate 2 appointments for my 92-year-old father with Alzheimer's disease. It took me 25 seconds to book an airline ticket to go to New York City so I could take care of him myself. But you know, despite all that inefficiency, in the end, it's social factors, our socioeconomic status, the environments we live in, and our lifestyles that are the major contributors to our health. It's actually not the medical care we get. That's a pie chart of what contributes to our health, and you can see that more than 60% of what contributes to our health is what we eat, what we drink, what we smoke, what we don't smoke, our lifestyle. It's our socioeconomic status, it's where we work, it's our environment. It's whether we live next to a lead smelter or not. Only about 10% of it is the health care that we get. Yet, we spend 99% of our health care dollars fixing many of the problems that we could prevent in the other side of that pie. And you know this better than me. That's because we don't have a system that focuses on health. We have a sick care system. And we have a system that separates physical health from mental health, from dental health, one body, 3 separate systems, 3 separate cultures. It's got waste and it's got inefficiency. We pay for quantity, not for quality. We pay for the number of tests. We pay for hospital admissions. We don't pay for health. And even within all of that spending, the billions and trillions of dollars that go into healthcare, we focus too little on, quite frankly, some of the things that matter the most. Mental health care. About 1 in 4 adults in our country suffers from a mental illness in any given year, and about 6% a serious mental illness. Those problems take an incredible toll on our families and on our individuals. Patients diagnosed with a serious mental health problem are likely to die 25 years earlier than the rest of us, and the care costs are tremendous. Mental health problems are amongst the costliest illnesses in our country, and individuals with chronic health problems who also have mental health problems have even greater health care costs. So take, for example, Mr. Davis. He's a gentleman I know in Oregon. He's 30 years old, and he's living with schizophrenia. And he had been showing up to the emergency room 40 times a year. But it wasn't his mental illness that was causing him to go to the emergency room. It was actually his asthma. He also had asthma. And when he would get short of breath, he would get anxious. He would call 911. They would pick him up. They'd take him to the ER. He was treated and generally released the same day. Treated and released, treated and released, treated and released 40 times in a single year. That's actually the commerce of our healthcare system. Now, there's a happy ending to his story, but you're going to have to bear with me for a little bit. Another divide is cost. We know healthcare is costly, and you've all seen these graphs 100 times. This one tells us that healthcare spending is going to double in the next decade. This one shows us that health spending is growing faster than any other economic indicator. This one actually compares a percentage increase in healthcare costs to, at the bottom, its gross domestic product and workers' wages. Healthcare has become so expensive no one can afford it. Businesses can't afford it, individuals can't afford it, our states can't afford it, our federal government can't afford it. Here's another graph. This one shows on the left-hand side, the top 2, the red and the blue, that's the growth of premium and healthcare premium, and the other is workers' contribution to premium, as compared to the bottom two lines, which are silver and gold, and those are earnings and inflation. And the other one on the right there shows the percentage of median family income that goes to health insurance. In 2001, 12% of median family income went to health insurance. It's expected to be 31% in 2021. Can you imagine for a minute a third of the median income being spent on health care? And the sad truth is we have no national policy on health care costs. And quite frankly, we're unlikely to have one anytime soon. And the tragedy is that those high health care costs are drowning our families and our states. And they're drawing dollars from other vital services, from family budgets, from education, from transportation, from the arts, from early childhood. But you didn't invite me here to tell you about all this, because my sense is you know all this, and you didn't invite me here to repeat our problems time and time again, that healthcare is too expensive, that the problems are uneven care. I think what you did is invited me to tell you a little bit about your neighbor to the south. And one of the ways that we looked at trying to actually do something about this. You know, traditionally, all of us in this room have had the same approach to healthcare costs. We've basically done one of three things for, it's probably been the last 30, 40 years in this country. When healthcare costs have gone up, we've cut people from care. States have done that from time to time. Businesses do that by making it so unaffordable that families no longer can afford family coverage. They cover the worker. We cut provider rates. We're great at doing that in government, but my guess is, I know a lot of people in this room, you've had some experience in cutting provider rates, and we cut services. We no longer pay for certain things. We don't pay for teeth, we don't pay for eyes, we don't pay for backs, we don't pay for feet. And the thing is that one, those things don't go away. The people don't go away. The services don't go away. The cut in payments gets shifted onto somebody else. When we in Oregon as a state would cut provider rates, others would raise rates. And so I stand here today with 30 years of all of us in this country doing this. How's it worked? Is healthcare any less expensive? No, it's not. So with that in mind, back in Oregon a few years ago under the leadership of Governor Kitzhaber, and with the help of hundreds, actually thousands of people, we had community meetings around the state to look at how we can tackle this problem. It resulted in some bipartisan legislation and in our creating what in essence is a fourth path to changing that healthcare trajectory. And the path is this: stop cutting services, stop cutting benefits, stop cutting payments, stop cutting people, fundamentally re-engineer care and change how care is delivered. To do a bunch of things: reduce waste, improve health, create some local accountability and ownership for health, align financial incentives, pay for performance, create what we're all looking for is fiscal sustainability. It means an emphasis on primary care and prevention, integrating mental health and physical health, focusing on the 20% of the population that drive 80% of the costs, people like Mr. Davis, who's one of those people, and assuring that care is based on the best evidence and science. To implement this model, we created what are coordinated care organizations. They're actually pretty simple. We have now 16 of them in our state, caring for about 95% of our state's Medicaid population. And what they are is they're organizations that are locally accountable. They're governed by a partnership between the three elements that you would want to be accountable for healthcare. They're governed by healthcare providers, meaning doctors and hospitals and others. They're governed by consumers. There's an important piece. And they're governed by those taking financial risk. In some cases, those are insurers. In other cases, there are others. But it's those three components that equally form together to govern these organizations. They have strong consumer advisory councils. They have a global budget that grows at a fixed sustainable rate, 3.4%. No more actuarially based rates. These are rates that say we're looking to deliver high quality health care, and it will grow at 3.4%. But this is a budget, that's what we can afford. 3.4% is in line with other domestic economic indicators. But with that comes flexibility and the ability to use those budgets however you want to improve health. Mental health, physical health, and dental care are all assumed within that same budget. And these organizations are not just responsible for the money, they're responsible for outcomes. And they receive incentives for quality. A portion of that global budget is paid for based on outcome. We started in the first year at 1%. It's now 2% of that budget, and it will grow every year so that more and more of payment is based on quality, not just based on getting a budget. There's really five foundations to this. One, it's about benefits and services being integrated and coordinated. That's number one. Number two, a single global budget that grows at a fixed rate, something that's predictable for all of us, both for consumers, for payers, and for providers. But it's not just about the money. It's also about metrics and standards for safe, effective, and better care. And it's about the biggest thing we lack in healthcare, local accountability for the dollars and for the outcomes. And then lastly, with that local accountability comes flexibility. We received a waiver to do this from the federal government. The federal waiver went into effect in 2012. It called for us establishing these CCOs to deliver the services in our Medicaid population, flexibility to use federal funds as deemed necessary, and oh yeah, we got a small amount of money to help us do this. We got $1.9 billion over 5 years to help implement this. Now, one would think that that's a pretty good sweetheart deal, but the truth of the matter is there's some serious accountabilities that we had. This was not a sweetheart deal. Oregon agreed to reduce spending in Medicaid by 2% per capita off from predicted Medicaid trend. So to give you an idea, that means that for that $1.9 billion investment, shared between the state over the next 10 years, shared between the state and the federal government, is a $4.9 billion return on investment by lowering trend 2%. So a good deal for the federal government, a great deal for the state. We had to do that by not reducing benefits, services, or eligibility. And there are financial penalties. If the state doesn't follow those financial trends, then we need to pay those dollars back. We also have strong criteria for quality, clear, measurable outcomes that we have to deliver on quality, or likewise, we face penalties that we have to pay back some of those dollars. And there are issues around having to be more transparent with data and information and to make some investments in workforce. And the whole goal of this has been to move from a system which before CCOs had fragmented care to after CCOs having coordinated patient-centered care, to move from disconnected funding streams with unsustainable growth to a global budget that grows at a fixed, sustainable rate that we can all count on, to go from where there were no incentives for providing quality care to a place where there are clear metrics and incentives for quality, from a place where there used to be limits on services to right now, there are no limits on services. We can use Medicaid funding as we feel best to meet people's needs. Our governor tells a story about a 90-year-old woman who lives on the fourth floor of an apartment building who has congestive heart failure. It's the summer, it's 90 degrees. Her apartment gets hot. She gets tipped into congestive heart failure, and she gets sent to the hospital. Spends a week in the hospital, $100,000 hospital bill, goes back home, is a lot better. But you know, her heart failure would have been better cared for. We spend that $100,000 readily, Medicare does. But a $200 air conditioner could have actually kept that woman from the hospital. That's what you can do with flexible services. Does anyone in here know what the ICD-9 CPT code is for an air conditioner? No, we could never pay for these things before because they don't have codes. Now, this is something we can do. Moving from a health system which is disconnected from population health to a health system that's very connected. These CCOs need to have community health assessments. They need to have plans for how to improve the health of their populations. And we've gone from a limited partnership to where communities are really accountable. What are we seeing? We're about 2 years into this. CCOs are living within their budget. The state's meeting its commitment to reduce costs. We've got progress on meeting our quality measures. We're showing race and ethnicity data, and it's not pretty. It shows that there are huge disparities, but it shows us where we need to start. So here's how it's actually going. This is 2003 compared to 2001 before CCOs. And I would remind you that we were a very managed care state prior to this. This isn't taking an unmanaged population and now managing it. We had strong community-based Medicaid managed care. And nevertheless, in the first year of our CCOs, we saw ED utilization, visits decrease 17%, costs decrease 19% as compared to 2011. Primary care visits up 18%, primary care spending up 20%. Adult admissions for such ambulatory sensitive conditions as asthma down 18%, chronic lung disease down 32%, heart failure down 27%. Now, mind you, these are dealing with some of the same people and same organizations that 5 years ago when I went to negotiate rates with, they told me, we can't do any better. We are already managing the blank, blank, blank out of our population. And it's been amazing to see what's happened in a year, what communities have been able to do. Patient-centered primary care and home enrollment up 52%, developmental screening for children up 58%. We've got transparency. This data is reported quarterly. This is a terrible graphic, but a good example. This is a page from a quarterly report. It shows by CCO, all the CCOs listed. This is emergency department utilization. The silver is where they were in 2011. The orange is where they are in 2013. The goal was to move from the right to the left. That middle line is the benchmark we're striving for. People are making progress. This, another difficult graphic, but good example. This is the same emergency department utilization, but now this is broken out by race and ethnicity. It shows us where we need to focus and how we need to do. And probably the most important thing that this has done in our state is taken us from being competitors to being collaborators. For the first time, we have health systems, doctors, hospitals, insurers, consumers, sitting down at the table, understanding that they are part of the same problem, that they need to be part of the same solution, that they have a dialogue, that they're working it out. We have communities in our state, small communities, where the hospital administrator and the mental health director never knew each other prior to this, yet they've lived in the same community for 10 years. It's a start. We've got more work to do. We've got to be able to move this. Next steps are to begin to move this into public employees' benefits, into the insurance exchange, into the commercial market, because in our state, like in your state, most providers care for not just Medicaid, but commercial and other business as well. And unless we can align those incentives, we're going to make it very, very difficult for providers in our state. As we do that, you see a tremendous savings. This is from Governor Kitzhaber's new budget for 2015. This shows at the top, the dotted line is what state spending on health care would have been had we not instituted these reforms. The bottom solid line is what our budget's being based on, which is instituting those reforms. This year's governor's budget assumes several hundred million of savings, and over the next decade, it's actually over $1 billion in savings due to actually making people healthier. It doesn't come from cutting benefits, it doesn't come from cutting services, it doesn't come from cutting payment rates. It comes from innovation, it comes from focusing on chronic illness, it comes from what we can do around integration, it comes about alternative payments for quality and for outcomes, more community health workers. This is what it does. So let me tell you about community health workers. Let's go back to the story of Mr. Davis. Well, Mr. Davis, his care team actually hired a community health worker to go visit him, check on him, make certain he was taking his medicines, and see him almost every couple of days over the course of a year. After having done that, Mr. Davis stopped going to the emergency department. His health care costs decreased 90% over the course of a year. He was healthier and he was happier. What is the code to be able to pay a non-licensed community health worker? There isn't one. And yet now in Oregon, it's hard to throw a stone without hitting a community health worker somewhere in our emergency departments, our primary care offices, and elsewhere. It's investments like this that actually are saving money. This isn't easy, it's hard. You need to make some investment in making this happen. We created a transformation center, we've got learning collaboratives. There's a lot of investment that needs to be done to make this happen. And there are a lot of challenges. Time, resources, and expectations. We actually did this big change without making a lot of financial investment. We made a lot of investment in sweat equity. Change is hard. Integrating behavioral health and physical health has enormous challenges, as you well know. Different payment, different cultures, different way care is organized, issues around how you share information. But when you get people around the table, it's amazing how suddenly you can develop solutions. Integrating dental health care, similar challenges. And there's more challenges. We face penalties, we face training issues, we face workforce issues, we face a host of issues. But as I stand here today, in the beginning of 2015, I can actually see for the first time in our state and around the nation that we're beginning to bend that arc. Moving people across that bridge, across that coverage divide, is certainly the first step. It's what's got to happen. It's the start we all need. It's the start we needed in Oregon. It's what you need here in Washington. The challenge now for the rest of us is, what do we do next? How do we tackle the pressing issues of affordability? How do we tackle the issues of uneven quality? How do we do something for the first time about health disparities? How do we combat the isolation of mental illness? How do we do something about the destructiveness of substance abuse that eats away at our families, at our individuals, and at our communities? How do we finally do something about the epidemic of childhood obesity in this country? All of these and more are going to define us and the future of our healthcare system. But I do really believe that we're bending that arc and that we are beginning to see a change. I look forward to seeing how that change develops here in Washington. Thank you.
Thank you, Bruce. That was That was great, and it's great to see some of those updates with how those CCOs are going in Oregon. We've got a little bit of time, so I want you to be thinking about some questions. We've got several minutes here for questions, but I wanted to, while you're thinking about that, start out and just ask you, as you were speaking, when you think about the triple aim, cost, quality, and then the patient satisfaction focus, and you take the work, for example, of what the CCOs have done, going forward, if you were to project out the next 2 years, where is the emphasis, or where's the area where either you've learned something new about how we might have to tackle one of those pieces of the triple aim, or where it may be the most challenging for us?
It's a great question, Don, and I think the biggest challenge is what I was alluding to at the end. When you look at this from both the consumer and provider perspective, providers take care of a whole array of people. And what we've got to do is have the same triple aim. If a CCO has one idea what the triple aim is, and Regence has another idea what the triple aim is, and Medicare has another idea what the triple aim is, the biggest challenge is how we align all of that, and how we can, for the first time in a lot of our communities, we've got hospitals, doctors, nurses, public health all working together around a common set of goals. But it's been a small segment. It's been about, Medicaid's now 20, it's going to be soon 25%. The biggest challenge is how we extend that throughout. And I think that's going to be really difficult. It's going to be a challenge, and it's going to take some real leadership, particularly on the Medicare side.
Yeah, that's great. So I'd like to open it up if folks have questions, and we got people that'll come around with a microphone here for anyone that's have a question. Just put your hand up. We got one right up here in the front.
So my impression is that in Oregon, on the Medicaid side, you didn't have, prior to this, a robust system of competing health plans. So you have created, in essence, cooperative bodies that are community-based. And as you try then to scale up your reforms to the commercial sector and the Medicare sector, which are indeed competitive-based with multiple competing health plans, what sort of potholes and challenges do you think are ahead of you there, and is that at risk of unraveling your more coordinated approach at the local level?
Well, although we had locally based competitive managed care, I wouldn't say it was the most collaborative. My experience was we had hospital-run managed care plans that were very favorably inclined towards hospitals and not so favorably inclined towards others. We had doctor-run managed care plans that were favorably inclined towards doctors and not towards others. And so I would say we've actually created a collaborative environment. One of the questions that I get asked a lot is, so how would this work elsewhere where you don't have those community-based organizations? And I think, I think there's a lot of peril out there, and this could all unravel. But what I've begun to see is, I think if people see results, I think results beget results. And I've seen, and I was just talking with one of the leaders of one of our CCOs who's here today, who sees some of the ability to bring people around the table and collaborate applicable to other states and other communities that don't have the same degree of cooperation. I think if people actually see something in it for them, that there will be a strong future for this. If providers see that this can work for them, if consumers see that this can work for them, if payers see that this can work for them, and if they all feel that they're a part of this solution, they all feel ownership, and they all feel that they can help in decision making and that they can equally share benefits and risks, I think that there's a a lot of strength in a model like that. But, you know, we're at the very beginning. And I think time will tell. And, boy, there are more potholes in the road ahead than I think one can count.
Other questions? Yes, we got one right up here at the front table.
I'm another interloper from Oregon,
Right.
and I happen to be a state employee, and I noticed on one of your slides you had some plans for public employees to do some of the purchasing. If the audience is interested in that topic, would you mind giving us some heads up?
Yeah, sure. I appreciate all that you've done, and appreciate the question. And it really is about how we can start to extend this. You know, you here in Washington actually were a step ahead of us. Created a health authority before we created a health authority. And not that we're competing as states, but I think the whole idea was, you know, states purchase a lot of health care between Medicaid, between public employees, in our state, Oregon educators. You know, now with Medicaid expansion in our state and many communities, the state purchases somewhere between 25% and 35% of the lives in a community. And in some towns like Salem, which is a company town, you know, much like Olympia, you know, my guess would be it's over 50% between public employees and Medicaid and the like. And so the question is, how do you really begin to align some of that? We started this in Medicaid, and now we've got, we're purchasing for public employees in some of the same ways. Not necessarily looking for a quote-unquote CCO, but looking to buy what are, in essence, those 5 foundational pieces. Who can sell us care that's coordinated? Who can sell us care that will grow at a fixed sustainable rate of 3.4%? Who can sell us care that will promote quality and have these outcomes and deliver on them? Who will be accountable for that? I mean, that's really what we're looking to purchase, and we've had state purchasing now that is purchasing through the CCO model, so to speak, for public employees. We hope that this will extend onward, but, you know, as the question before was, you know, the jury's out. This is a long road to hoe, and my guess is things will evolve and change in a lot of different ways. I've been in this business long enough to know that, you know, innovations and changes in healthcare, we've seen a lot, Don, haven't we?
Yes, we have. More to come, too.
Exactly.
Well, great. I know that DJ is going to be coming up and talking a little bit more about the logistics after this, but I want to, let's give a round of applause to Dr. Bruce Goldberg here for sharing with us today. Thank you. Thank you, Bruce.
Thanks.